2, 1. Please start, sir. We are live.
Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, extend a warm welcome to all of you to the 6th episode of Nephro Live. And today, we focus on a clinically challenging and increasingly relevant topic, that is cardiorenal syndrome, what physicians should know. And as we are trying to bridge speciality through this session, this episode aims to equip the physician with practical insight between the complex interplay between the heart and the kidney. And our primary objective is to understand how early recognition and timely intervention can improve outcome in our patients. And we are once again privileged to have with us our distinguished course director, Dr. Dinesh Kullar, sir. He is a chairman and head department of nephrology and renal transplant medicine at Max Super Specialty Hospital, Saket, New Delhi. Dr. Kullar's visionary leadership has been the cornerstone of this academic journey, guiding each episode with his clinical wisdom and thoughtful moderation. Welcome, sir. And now I request you to take this session forward and introduce our faculty for today's program. Over to you, sir.
Thank you very much, Dr. Mithilesh, and a warm welcome to everyone who have joined us today. It's a pleasure, and I eagerly look forward to meeting you all through Nephro Live. And we are in the, as I already been described, in the 6th edition of the second of the series of Nephro Live this year. And it's always a treat. We are wanting to disseminate as nephrologists, for which I request all my friends from across the country to be part of this endeavor to disseminate the knowledge pertaining to the nitty-gritties of chronic kidney disease, its management, because we know over the last many years, there has been a lot of progress in this field, and we certainly need to update our knowledge as far as this is concerned. So the format of this meeting is, first, I would be requesting Dr. Simran Sani, who is a consultant here in our department at Max Super Specialty Hospital, Saket, working as an associate consultant in the department. A person with a brilliant track record. She has excelled in her academic career throughout, and she did her DNB in nephrology from Medanta Hospital, Gurugram, about a couple of years ago, after which she has been here with us and making huge and very important contributions to our departmental functioning, be it patient care or the academics. And it's a pleasure to have Simran in our department. She has published numerous articles, and she, as I had said, has also been presenting regularly various talks at different prestigious forums. She's going to talk about the topic for today, which is cardiorenal syndrome, because we know that there is a crosstalk, a certain crosstalk between heart and the kidney. And if we were to visualize what is happening individually at these two organ level, we do realize that there is certainly a crosstalk. And when there is something going wrong in one, there is definitely the other organ also gets equally hit and troubled. You try to set one right, you burn your fingers because the other organ is going to get in further trouble, and vice versa. So that is why we need to know for sure as to where do we stand in 2025 as far as this very important topic, which is cardiorenal syndrome, is concerned. And for this, we have elite panelists. And as is always the case, I couldn't have thought of better people than who have joined us today. From the field of cardiology as well as nephrology. So it's a treat for me to invite my very dear friends from across the country who always do a great job. And today I can assure you is going to be no exception. The stalwarts, the best known names across the country as far as nephrology and cardiology is concerned. We are joined today by Dr. V.K. Chopra. So it's my pleasant duty to introduce Dr. V.K. Chopra, who is one of the best known figures in the field of cardiology in this country, at least. He's currently working as Senior Director, Clinical Cardiology, Heart Failure and Research at Max Super Specialty Hospital, Saket. He is almost like synonymous with when it comes to management of heart failure. I mean, it's not just about his clinical acumen, but what he has achieved via a lot of research activities as far as this particular field is concerned, in addition to whatever else he may have done in the field of cardiology. But as I said, he is synonymous to all of us as the person when it comes to a cardiologist with great deal of experience with management of cardiac failure. So he has vast experience, as I said, and during this journey, he has been associated with many awards and accolades. So he's been the founder president of the prestigious Heart Failure Association of India, and he's been on the editorial board of the, you name it, and he's there. I mean, as far as the prestigious journals are concerned, and of course. He's been the national lead investigator, and as you can see, there's a never-ending list. I mean, so the kind of contribution he has made from India towards some of the best known trials over the last few decades. So it's a pleasure, it's an honor for us to have Dr. V.K. Chopra join us today. Up next, Dr. Sanjeev Saxena, a very, very dear friend of mine, an association with which has gone on for many, many decades, a person whom I have personally always admired for his sheer clinical acumen, his sense of humor, his absolutely brilliant academic record. I mean, having done his all the undergraduation, the post-graduation, as well as his DM in nephrology from the prestigious All India Institute, and thereafter he's been working as the chairman and head of Department of Nephrology at PSRI Hospital in New Delhi. As I said, it's always a treat to know him and learn from him. The kind of sheer experience, the practical tips which he always gives to his friends as nephrologists and to his patients is remarkable. And of course, he's a regular examiner for at the DNB level. Many publications to his credit and many awards also. Obviously, well deserved, all of them. And he's been an editor of a few very important books as well. Also has taken keen interest in research activities, having been part of PI of many of the prestigious landmark trials which he has been associated with. Up next is Dr. Kamal Kiran Mukavali. He's again a very dear friend, a very close, a great friend to have. I must confess, always a treat to interact with him. His energy, his warmth is so infectious. He just has to be in a particular room to make it full of warmth and laughter. And of course, he is a brilliant nephrologist and a very well-known figure from Telangana. He is currently director of Department of Nephrology and Transplantation of the Medicover Hospitals. After doing his training from Bangalore, he also worked at Adelaide, Australia for a couple of years before he moved back. Has contributed immensely, hugely through his publications in the various national and international journals. And of course, he is a regular feature and an invited faculty at the various national conferences. But what is also very, very important at a personal note is his keen interest in Harley Davidson. So he's almost, for me as a friend, he's synonymous with Harley Davidson. He's part of that group. You would have noticed those people, energy beyond imagination, who are a part of troop and group who travel across the length and breadth of the country to be to and take their Harley Davidson. So it's always a treat to know from him as to what is the latest as far as their exploring the country is concerned. But yes, when it comes to nephrology, it's so very important to talk to Kamal whenever in doubt. And Kamal has some beautiful answers to many of the difficult, tricky clinical situations. So thank you so much, Kamal, for joining today. And last but not the least, Rushi, another very dear friend, again a wealth of knowledge. Rushi is brilliant. He is a very famous nephrologist from the western part of the country, Mumbai in particular, and of course at the national level. He is one of the most sought after nephrologists, not as I said in just in Mumbai, but then probably many other parts of the country. A very, very intelligent nephrologist who is attached to various hospitals. Predominantly, he's director at the prestigious Jaslok Hospital is also attached to the HN Reliance Hospital. A gold medalist, I think, is a very, very brilliant academic record. He's held all his academic career. And again, as I said, he's a very sought after figure when it comes to solving the clinical difficult situations in the field of nephrology. And his interests are varied, and you name it, and he could be impressing you with his sheer knowledge in the various aspects of nephrology. And of course, he's been a part of many landmark trials as well. So with this introduction of the NEET panels, you can all see, I'm sure, the kind of excitement I have because I'm surrounded by a galaxy of stars today, and today is no exception, as I said. So first to Simran, who is going to talk to us about the basics, absolute basics of cardiorenal syndrome. So whether you start from the cardiology side and from the nephrology side, there is so very often a common meeting point, and this is what she is going to tell us today. Recapitulate our knowledge. What is the latest, and how do we manage these difficult situations, and which can actually at the same time be very, very rewarding. So we certainly need to brush up our knowledge, and certainly it'll be followed by a panel discussion, which is, I'm very sure, going to be very, very useful. So please stay tuned, and over to you now, Simran, for talking to us about cardiorenal syndrome.
Thank you, sir, for your kind words. It is my privilege to deliver this talk on cardiorenal syndrome on such an esteemed platform. And I would like to extend my gratitude to Dr. Khullar as well as the entire team for giving me this opportunity. I'm going to start with the very basics on what exactly is cardiorenal syndrome. It is basically a spectrum of disorders involving both the heart as well as the kidneys, where an acute dysfunction in one can lead to an acute or chronic dysfunction in other. But why this topic is so important is because patients of cardiorenal syndrome have an extremely poor prognosis, and there is a greater risk of mortality and morbidity when compared to the patients who have either of these disease entities alone, as it is depicted in this study which was published in European Heart Journal. This is basically a clinical database of collected over a period of 10 years in hospital in Portugal, which showed that patients who had cardiorenal syndrome had an increased risk, in fact, the highest risk of all-cause mortality and a highest risk of cardiovascular death when compared with the control group. And also it can be seen that the hazard ratio is 7 in patients with cardiorenal syndrome, and it is quite large when compared to patients who only had CKD or only had heart failure. So that is why it is extremely important that we treat this entity and try to prevent the progression of chronic kidney disease and cardiac dysfunction. Now, starting with the types of cardiorenal syndrome, there are 5 types of cardiorenal syndrome. Type 1 is basically when a sharp decline in in cardiac function leads to acute kidney injury. Type 2 is when a chronic cardiac dysfunction causes CKD. Type 3 is just the reverse of type 1, in which an acute kidney injury can lead to an acute reduction of cardiac function. Type 4, in which CKD patients ultimately develop the chronic cardiac dysfunction. And type 5 is when any disease or any illness which simultaneously involves both the kidney as well as the heart. Among these, type 1 cardiorenal syndrome is the most common. Now, I'll discuss about pathophysiology. Type 1 being the most common, I'll take that up first. It is an acute decompensated heart failure which leads to acute kidney injury. Now, this decompensated heart failure can occur either after an ischemic event or after a non-ischemic event. And this basically leads to both hemodynamic changes and non-hemodynamic changes, ultimately causing acute kidney injury. So whenever there is a failing heart, there is inability of the heart to produce enough effective arterial blood volume, which leads to renal hypoperfusion. Along with that, another important concept is the concept of renal venous hypertension, which is caused by central venous congestion. So whenever in a heart failure patient, there is increased interstitial pressure, there is tubular collapse in the kidneys, and ultimately parenchymal damage can also develop, which leads to AKI. Now, important point to be noted here is that these hemodynamic changes itself cause non-hemodynamic changes as well. That is, they activate sympathetic nervous systems, activate the RAS system, endothelins and vasopressins, which are vasoconstrictors and also contribute to acute kidney injury. Now, coming to the type 2 cardiorenal syndrome, about 63% of the patients of chronic heart failure have chronic kidney disease. And that is why this syndrome is very important. The pathophysiology is basically the same as type 1, but all the things are now chronically there, like chronic decreased effective circulatory volume, chronic activation of RAS system, sympathetic system. And because chronic heart failure, there will be a systemic inflammation always present, which leads to oxidative stress, inflammation, ultimately leading to tubular injury, glomerular injury, and the patient develops CKD. Type 3 cardiorenal syndrome is just the opposite of type 1. The symptoms of acute kidney injury produce some pressure on the heart and cause acute cardiac dysfunction. Like oliguria can cause volume overload and produce myocardial injury. Hyperkalemia, very commonly seen, can cause fatal arrhythmias and even sudden death. Metabolic acidosis can also produce pulmonary vasoconstriction, putting pressure on the right side of the heart. And AKI itself is a risk factor for acute coronary syndrome. Type 4 is basically CKD causing a dysfunction, chronic dysfunction in the heart. The CKD patients are always in a state of chronic inflammation, which produces again reactive oxygen species harming the heart. There are high risk of vascular calcification in patients of CKD because of hyperphosphatemia, hyperparathyroidism, hypertension. Also a state of insulin resistance, lipid dysmetabolism, all these contribute and put a negative impact on the heart, producing chronic cardiac dysfunction. Now coming to the type 5 cardiorenal syndrome, in this basically the systemic diseases like inflammation, sepsis, or diabetes, amyloidosis, vasculitis are affecting the kidneys and heart at the same time by the same mechanism, by causing hypoxia, or by activation of the inflammatory cytokines, hemodynamic changes, and the activation of the RAS system, affecting both kidney and heart simultaneously. Now, there is another concept called cardiovascular kidney metabolic syndrome, which was proposed by the American Heart Association in the year 2023. This is basically a health disorder which is caused by connections among heart diseases, kidney diseases, diabetes, and obesity, leading to poorer outcomes. Various stages of CKM has been described. It basically starts with stage 1, where there is only one risk factor, that is obesity and impaired glucose intolerance. In stage 2, this obesity, impaired glucose intolerance causes the patient to progress to stage 2, and where other risk factors like diabetes, hypertension, and even CKD develops. Stage 2 then progresses to stage 3 and stage 4, where cardiovascular system gets involved. And now this CKM syndrome is being targeted in future by the drugs. So now coming to the management of cardiorenal syndrome. In acute decompensated heart failure or in any heart failure, in fact, the kidney responds by retaining sodium in water mostly, and hence these patients are always in fluid overload. So that is why the decongestive therapies, diuretics remain the main line of treatment in improving the patient symptomatically, especially of patients of type 1 cardiorenal syndrome. And loop diuretics are preferred over thiazide diuretics. Now, among the loop diuretics, torsemide, even though it has a longer half-life, better bioavailability, but it is still not proven to have a superiority over furosemide. In Transform Heart Failure trial, as shown in the slide, torsemide, when compared to furosemide, did not result in a significant difference in all-cause mortality over 12 months. The other question that is very frequently asked is that in acute decompensated heart failure, whether continuous infusion of diuretics is better or bolus. So this question was addressed by a trial called DOSE AHF trial, which showed that there was no significant difference in the symptoms of the patient and no significant difference even in the creatinine levels when diuretics were either given in bolus or in continuous infusions. It also studied low dose and high dose diuretics. And the only difference between low dose and high dose was found that high dose diuretics was associated better diuresis and more favorable outcomes in secondary measures such as weight loss. But other than that, symptomatology as well as the change in creatinine was not significantly different between the two groups. Another important aspect of diuretic resistance is seen in patients of acute heart failure. Why it is important to study this is because it is associated with increased mortality and it must be curbed. Why does diuretic resistance develop is because of various factors, like there is decreased in renal blood flow in cardiorenal syndrome, hypoalbuminuria, because of which the diuretics are unable to reach the kidney, competition of diuretic entry into the nephron by the increased organic anions, decrease inadequate dose of the loop diuretic, and the most important one being the distal tubular hypertrophy. This occurs because the loop diuretics increase the sodium content in the distal tubule, which causes its hypertrophy and hyperfunction. And thus, it is important to combat this, and thus the addition of thiazide diuretics before loop diuretics is very useful to treat diuretic resistance. Now coming to ultrafiltration, various clinical trials over the last decade have shown that there is greater risk than benefit in using ultrafiltration as a strategy of volume management in patients of heart failure. In fact, the American College of Cardiology does not recommend ultrafiltration as a first-line treatment, and diuretics still remain the first treatment of choice. The 2021 European Society of Cardiology for the treatment of acute and chronic acute heart failure showed diuretics being the first class agents, as I have already discussed. Also, the second, hypoperfusion, the patients of acute decompensated heart failure remain hypoperfused. In those cases, even using inotropes or vasopressor support has been recommended as a class 2 recommendation. Now, I will move on to the chronic heart failure. As we all know, heart failure is divided into heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. Now, as per the 2021 ESC guidelines on heart failure, RAS blockers, ARBs, ARNIs, beta blockers, mineralocorticoid receptor antagonist, SGLT2 inhibitors, as well as diuretics. These have been given class 1 recommendation for treating heart failure with reduced ejection fraction. As for heart failure with mildly reduced ejection fraction and preserved ejection fraction, SGLT2 inhibitors and diuretics have been given class 1 recommendation as per the ESC 2023 update. Now, I will be talking about these drugs one by one. So first, coming to the RAS blockers. So what does the... sorry. Are my slides moving? Hello?
I think they're fine. We can see that.
Yeah, sorry. So I will start with each drug. Now starting with the RAS blocker. The RAS in the angiotensin 2 basically has a negative impact on the heart as well as the kidney by causing vasoconstriction, fibrosis, and sodium and water retention. Hence, ARNIs, which are angiotensin receptor neprilysin inhibitor, the valsartan part of this drug, which is an ARB, blocks this angiotensin receptor, hence prevents these effects on the heart as well as the kidneys. The other part is whenever there is heart failure, the natriuretic peptide system gets activated. All these ANP, BNP, and CNP cause increased natriuresis, vasodilatation, and decreased fibrosis. But there is a molecule called neprilysin which converts them into inactive fragments, and hence sacubitril, which is a part of ARNI, inhibits this neprilysin and increases the action of these molecules. Hence, ARNI are playing a very important role in cardiorenal syndrome. Another important point to be noted is that bradykinin levels are also increased when we use ARNI, and hence we should not combine sacubitril with ACE inhibitors, because if we use sacubitril with ACE inhibitors, then the level of bradykinin will go up, and it can lead to severe reactions like severe angioedema. Because of all these things, ARNI has been given class 1 recommendation in heart failure with reduced ejection fraction, and class 2B recommendation in heart failure with mildly reduced ejection fraction. And it has some various advantages over ACE inhibitors. It causes less hyperkalemia. It can be initiated at a lower dose with the monitoring of creatinine and potassium levels, as well as with the advent of newer anti-hyperkalemic measures like sodium zirconium cyclosilicate. We are more, it allows the safe continuation of ARNI in patients of heart failure. Now, ARNI has been tested in various trials of like paradigm trial, tested compared ARNI with enalapril in heart failure with reduced ejection fraction. It not only showed a significant decrease in cardiovascular death and hospitalization due to heart failure, but also led to a slower rate of decline in GFR. Hence, very important for cardiorenal syndromes. Also, Paramount trial showed us compared ARNI with valsartan in heart failure with preserved ejection fraction. This trial also showed there was preservation of GFR with the group which received ARNI. Now, coming to the one of the major drugs which has been approved for heart failure of reduced, mildly reduced, as well as preserved ejection fraction is SGLT2 inhibitors. SGLT2 inhibitors, they act on the proximal tubule and inhibit the SGLT2, causing natriuresis, which not only decreases the blood pressure, volume overload, but also decreases the intraglomerular pressure by activating the tubular-glomerular feed. Other than that, it also causes glycosuria, decreasing glycemia, improving the glycemic control, and causing weight loss. All these factors are cardioprotective as well as renal protective. It has also shown to decrease oxidative stress and inflammation, also having a direct effect on the kidneys. Thus, SGLT2 have now been recommended in, as I've already told, in 2023 guidelines in all kinds of heart failure, as well as in patients of diabetes and CKD. SGLT2 inhibitors are recommended to reduce the risk of heart failure, hospitalization, or cardiovascular death. All these recommendations are class 1 recommendations. This has been come into recommendation thanks to all these successful trials like Emperor Reduced, Emperor Preserved, DAPA Heart Failure, and Deliver trial. Even SGLT2 inhibitors were studied in various CKD patients in Credence trial, DAPA CKD trial, EMPA kidney trial, and it showed that all these SGLT2 inhibitors had favorable kidney outcomes, favorable cardiovascular outcome, and hence even KDIGO now recommends to use SGLT2 inhibitors in diabetics and CKD, and also in non-diabetics patients who have urea or heart failure. Now, coming to the game changer, mineralocorticoid receptor antagonist Finrenone. This is a non-steroidal bulky molecule. Now, why I am calling it as a game changer? Because we all know aldosterone is kind of a villain in our body. It acts on the receptors on the kidney as well as the heart, causing increase in reactive oxygen species, causing increase in nitric oxide, and leading to inflammation, fibrosis, as well as vasoconstriction. So if we block these mineralocorticoid receptors, we are able to combat the inflammation and fibrosis. Also, we are able to combat the glomerular hypertrophy, fibrosis in the interstitium, as well as prevent the sodium retention. Why it is better than its steroidal counterparts like aldosterone, like spironolactone and eplerenone? It is because it has higher selectivity and a shorter half-life and no steroidal side effects. Also, it has been shown that Finrenone causes lesser hyperkalemia when compared to spironolactone. And it has also been successfully studied in Fidelio DKD, Figaro DKD trial, in which patients of diabetes and CKD were taken, and Finrenone was compared with placebo, and it has shown good cardiovascular and good renal outcomes. It has also been studied in Feinhardt's heart failure study, where patients of mildly reduced ejection fraction or preserved ejection fraction were taken, and Finrenone showed a significant rate of significant lower rate of total worsening of heart failure events, as well as death from cardiovascular causes when compared to placebo. Thus, now the fine heart meta-analysis has tested Finrenon in CKM, as I had already discussed this syndrome earlier. It has taken, this meta-analysis has included patients from these previous 3 studies and has shown that Finrenon has caused significant reduction in all-cause death, significant reduction in heart failure hospitalization, and significant reduction in the kidney outcome. And thus, Finrenon is recommended by ESC 2023 to reduce the risk of heart failure and hospitalization in patients of diabetes and in patients of diabetic and CKD patients. KDIGO has also recommended Finrenon in patients with diabetes with GFR more than 25 with normal serum potassium levels. Now, Finrenon, a lot of clinical trials are going on Finrenon, and this can actually change the way we treat CRS. So the Moonraker is a program which includes all the studies related in which Finrenon is being studied in heart failure, like redefine heart failure, confirmation heart failure, and finality heart failure. Whereas Thunderbolt CKD program consists of the studies in which Finrenon is being tested in CKD, like Find CKD is Finrenon is being tested in non-diabetic kidney disease, Confidence in diabetic kidney disease, Find1 in type 1 diabetics. So these clinical trials are definitely going to change the way we treat cardiorenal syndrome in the upcoming years. Now, a concept which is often missed is anemia. These patients of cardiorenal syndrome always have anemia. Most of the patients have anemia, and this syndrome is called cardiorenal anemia syndrome. Anemia is both an effect of cardiorenal syndrome, and also it can worsen the cardiorenal syndrome, and that is why it is important that we treat it. So at present, there are no guidelines directed management of anemia of cardiorenal syndrome. However, the hypoxia-inducible factor stabilizers because of the pleiotropic effect on lipid metabolism, decreasing insulin resistance, decreasing inflammation, increase EPO production. This may offer benefit in this population. We still need to have more studies on this to confirm. Whereas IV iron has been recommended by the ESC guidelines 2023 in patients of reduced ejection fraction and mildly reduced ejection fractions with iron deficiency to improve the quality of life as well as the heart failure symptoms. Now coming to new molecule, GLP-1 receptor agonist. This molecule acts on the pancreas, the receptors on the pancreas, and causes increase in insulin and decrease in glucagon. It also has a pleiotropic effect because it acts on the kidney, causes diuresis, causes natriuresis. It also has an important effect on heart by increasing the myocardial contractility, decreasing the fibrosis, and most importantly, it decreases the weight of the patient. Thus, this molecule is being studied widely. The STEP heart failure with preserved ejection fraction trial studied this drug and compared it with placebo in obese patients who had an ejection fraction of more than 45%. And it showed that patients showed symptomatic improvement as well as significant weight reduction. Also, the famous FLOW trial tested semaglutide in CKD patients with diabetes and successfully showed that the risk that semaglutide reduced the risk of kidney outcome and death from cardiovascular causes, again making it a very important molecule in cardiorenal syndrome. In fact, KDIGO has even recommended the use of GLP-1 receptor agonists in patients with diabetes and CKD over and above the use of metformin and SGLT2 inhibitors in patients who are who have not achieved glycemic control despite of use of the other 2 drugs. Now, the soluble guanylate cyclase stimulator. Its main action is to increase the cyclic GMP and cause increased vasodilation with advantageous effects on kidney as well as on heart. Thus recommended as a class 2 recommendation in heart failure with reduced ejection fraction who have worsening heart failure despite being on ARNI, beta blockers, and MRAs. So Victoria trial tested vericiguat in patients of heart failure with reduced ejection fraction, and it showed that the primary outcome of cardiovascular death and hospitalization was significantly reduced in patients of vericiguat as compared to placebo. Another important fact is that study showed that this molecule can be used in a wide range of GFR. That is, this study took patients up to GFR of 15, and we can safely use this drug in CKD patients without having any risk of hyperkalemia. So, in spite of all these great molecules, there are still exciting molecules which are coming up. One of them is the aldosterone synthase inhibitor. Now, why do we need this molecule? It is because aldosterone also has some non-genomic effects on the heart and kidney, which cannot be blocked by finerenone and spironolactone. Thus, we need this aldosterone synthase inhibitors. But the point to remember is that these molecules cannot be used just alone. They have to always be combined with the RAS blocker. Otherwise, the level of angiotensin 2 will increase. Thus, various clinical trials are now taking this molecule into account. And one of these trials is the EASY kidney trial, which is going to assess the cardiorenal efficacy and safety of combining SGLT2 as well as aldosterone synthesis inhibitor in patients of CKD who are at risk of progression. Another exciting trial coming up is the BAXTIO Pacific trial, which is going to study about renal outcomes as well as the cardiovascular mortality in patients of CKD and high blood pressure. And they are going to test the molecule baxdrostat in combination with dapagliflozin. Now, other management strategies in cardiorenal syndrome also include, like in type 4 CRS, we must manage the CKB-MD. We must manage dyslipidemia in patients of chronic kidney disease, chronic heart failure. Patients who come to us with acute kidney injury, especially patients who are admitted in ICUs, acute kidney injury must be prevented in these patients. And type 5 CRS, we must treat the underlying condition which is which is affecting both the kidney and the heart, and try to maintain a mean arterial pressure of 65 mmHg. I cannot go into the details of all this because of the paucity of time. Now, I would like to conclude by saying that cardiorenal syndrome is a concomitant bidirectional dysfunction of the kidneys and the heart, in which one organ initiates, perpetuates, and also accelerates the decline of the other, resulting in poor prognosis. Management, diuretics have been the cornerstone of management in symptomatic treatment, but their mortality benefits are yet to be proven. ARNI, definitely better than ACE inhibitors, and now recommended in heart failure with reduced ejection fraction. Finerenone, a game changer, currently recommended only in CKD and diabetes, but definitely with the ongoing trials, it is going to play a very important role in cardiorenal syndrome. SGLT2 has already made its place. It has been approved in heart failure and also in CKD patients up to GFR of 20. Correction of anemia and giving IV iron in heart failure patients should not be forgotten. GLP-1 receptor agonist is also recommended in diabetics and CKD. However, further trials are needed to include this in CRS. Soluble guanylate cyclase inhibitor recommended in worsening heart failure in reduced ejection fraction. However, further evidence is needed to use in CKD patients. In fact, Alpine 1 trial is being conducted, which will test it in CKD patients. And finally, the aldosterone synthase inhibitors, in which the trials are ongoing. And I hope with these new molecules coming up, we will be able to manage CRS early and prevent CRS as well, so that we can mitigate the impact of cardiorenal syndrome. Thank you.
Well, thank you, Simran, for that wonderful talk. And I'm sure everyone would agree there could not have been better justice to the topic. She has very beautifully covered all the relevant points. And I think this is something which is so very relevant. And the theme of today's meeting is what the physicians should know. And everyone in this group, including the nephrologists, the cardiologists, all the care providers to these patients must have at least the basic knowledge of what she has told us today. Thank you very much, Simran, for that wonderful thing. So let's have a discussion. If you can stop sharing your screen now, Simran, and so that we can have a very great and lively discussion, I'm sure. And then first and foremost is this question is to Dr. V.K. Chopra. Dr. Chopra, sir, Simran has given us typically a nephrologist perspective. And then obviously, when this term was coined, and this we know very famous nephrologist, Dr. Claudio Ronco, also was a part of it, and we were wondering as to who owns up this definition. So we know that when it comes from the cardiologist side, the type 1 and type 2, you will call it a cardiorenal syndrome. But then nephrologists were quick to realize that they were not wanting to let go of a golden opportunity. So they came out with something called a renocardiac, because we know the type 3 and type 4 are more renal to begin with, and then the heart gets affected. So what your take would be on this entity called cardiorenal syndrome from a cardiologist perspective? We heard a nephrologist talk about the concept of CRS. So let us briefly get to know as to what typically goes on in a cardiologist mind. So you're muted, sir. Can kindly
Thank you,
unmute
Dr.
yourself.
Fuller. First of all, my compliments to Simran for covering the topic so exhaustively. In fact, none of us needs to speak anymore after what she has spoken.
Thank you.
But anyway, be that as it may, I don't think now it is ownership of cardiorenal or renocardia. You know, the important systems in the body are all interlinked. But how did we get here? You all remember we started off by talking about cardio diabetes. Then it became cardio diabetes renal. But now that we have realized that it is not just cardiac, renal, diabetes, but there are so many other systems which are involved. For example, obesity, metabolic syndrome, dyslipidemia, hypertension, prothrombotic states, they all interact seamlessly to produce various problems. And most of them cause oxidative stress, dyslipidemias, endothelial dysfunction, which leads on to arterial thrombosis and plaque formation and worsening of heart failure. So given this importance, it was in 2023 that American Heart Failure Association expanded CB and kidney risk factors into a new group of syndromes, and they called it cardiovascular renal metabolic syndrome, CKM syndrome. And these are defined as systemic disorders characterized by pathophysiological interaction among various metabolic disorders, chronic kidney disease, and cardiovascular diseases. And this leads on to multi-organ dysfunction and high rate of adverse outcomes. So why did this happen? I think, as Simran has beautifully mentioned, most of it was driven by various trials. Because as the evidence started emerging, we all remember with ARMY that there was a strong benefit not just for heart failure hospitalizations, but also there was renal benefit that was incorporated. And subsequently, 3 other classes of drugs have been already accepted. SGLT2 inhibitor story, we all know that it was an unexpected benefit from EMPA-REG trial, where they found out that not just that it was safe, empagliflozin was just not safe, but it reduced the heart failure hospitalization with a tremendous benefit and renal endpoints. And that set of various trials, which she has mentioned, I'll not go into details. And with that, we know that SGLT2 inhibitors are not just important for preventing, but also now in treatment for heart failure and for SGL and renal disorders. And we are increasingly utilizing. The next was Finrenone. Again, she has mentioned that. And we tested this in fine arts trial. And of course, you had your Fidelio and Figaro CKD and so on and so forth. And that found out that, this particular group of drugs, which has been largely underused, not just in our country, but across the world because of the fear of hyperkalemia, did give very, very significant benefit in heart failure and renal dysfunctions. And paradoxically, the patients where it was most useful were the ones where it was not used because of hyperkalemia. Because sicker the patients, greater is the benefit that is obtained. So again, that has come into guidelines. Used carefully, it is a wonderful drug. And see, a few years back, it was all ARNI, then it was all SGLT2 inhibitors, then it is incretins which came in. I can tell you next 3 years are going to be major trials on aldosterone. She has already mentioned about aldosterone synthase inhibitor. We have already started trials on dextrostat and one on another drug called vicardostat, which is again an aldosterone synthase inhibitor. Both of them are going to test heart failure and kidney patients with the use of these drugs. Another group of drugs which is coming up very shortly is angiotensinogen synthase inhibitor. The drug is called zilebesiran. See, the way that we practice medicine is going to change very rapidly. The focus is on using drugs which are very safe, which are focused, targeted, and which we can use once or twice or thrice in a year. So zilebesiran is an attempt towards that. We already have inclisiran and things like that for unrelated dyslipidemia, which we require only 2 injections a year. So same thing is coming up in various fields of cardiology. The other thing was incretin hormones, GLP-1 receptor agonist. Again, this came through the various trials, STEP-HF trials dominantly, but also other trials. And they showed a very powerful effect in reduction of heart failure hospitalizations, in heart failure with preserved ejection fraction, and also renal benefits. So these are various things which are coming up. Now, the anemia story is, as far as heart failure is concerned, is slightly different. The lot of enthusiasm initially about IV iron, and they were included in the guidelines not to improve mortality, but to improve the quality of life and the heart failure hospitalizations. The new trial, FAIR-HF, which was published 2 days back, is negative. No improvement in quality of life, no improvement in heart failure hospitalizations. So it is still just a mixed bag. We still don't know which way things are going to go. Vericiguat, she mentioned, again, something which can be used in up to 15%. As far as heart failure with preserved ejection fraction and CKD is concerned, we still don't have any targeted trial. These trials have been done in which these endpoints were used and these patients were included, but still we have to see. So I think in a short, I can summarize that no longer can we live in separate silos of cardiology and nephrology. As I said, all these systems are interlinked. If we have to treat a patient, you have to have a reasonable knowledge about the cardiac effects, the renal effects, the metabolic effects of various drugs, so that we can derive maximal benefit for our patient. For example, SGLT2 inhibitors, diabetologists were not using it for years till Emparac came. And now suddenly everybody has jumped on the bandwagon and we are using it left, right, and center. So that would be my take on this. Moonraker trial, yes, Imran. Fine arts was one of them. 3 other trials are starting. 2 we have started already. Third one, I don't know whether it'll come to India or not, but it's going to start very shortly. So redefine and confirmation we are starting. Redefine we have started. Confirmation will start shortly. So let us see, exciting times ahead, and the next few years are going to tell us a lot more about which way to go. Thank you.
Thank you very much, Dr. Chopra, sir. And I think you have given us a great insight as to where are we in terms of the management and what does the future have in store for us. There's a lot of optimism one can see as what he has highlighted. And of course, the way he's talking about a whole lot of trials, including Moonraker, as far as the heart is concerned with Finrenon, and the nephrologists are not going to be left behind. We have Thunderball, which is going to be a step forward from where Fidelio, CKD, and Figaro left, and we have Confidence and Find CKD and so on and so forth. So I think, as you have rightly pointed out, lot of future. But then let's start from the absolute basics. And I think no one better than Dr. Saxena, with his huge and tremendous experience of managing such patients. Dr. Sanjeev, you heard again, and I'm taking you back to what Simran talked about, the classification of cardiorenal syndrome. But based on your experience and the way you look at these patients, do you think there is really a need for such kind of classification? Is it clinically relevant, or you will just look at the symptomatology and broadly keep them under the umbrella of cardiorenal rather than subclassifying them into 1, 2, 3, 4, and 5, and then go ahead with your management? What are your practical takes on that?
Thank you very much. And I think first and foremost, I must compliment Simran. Simran, you should not be an associate consultant. You should be a consultant from tomorrow. You really... And I'll tell you what, a couple of decades back, diabetes was a disease and obesity was a condition. Now it's the other way. Obesity is a disease and diabetes is a condition. Two other things that we have been taught for 40 years back. Dr. Venugopal, who was among the sharpest surgeons, cardiovascular surgeons, he came to realize that patients who post-op developed some sort of renal dysfunction, say 2 creatinine or 2.5 creatinine, stayed longer or died in the CTVS ICU. So he requested the nephrology department to get actively involved with him post-surgery, wherever this is. So nobody knew what is cardiorenal syndrome that time. Then we've been taught for ages that patients who have CKD die of cardiovascular disease more often before they reach the end stage disease or dialysis. So all this is just now what is happening, and exciting is the fact that the bulk of the drugs act both on the heart as well as the kidney. So this classification which seems to be so watertight is no more that valid. Whether it is primarily a kidney disease leading to poor cardiac function or a poor cardiac function leading to poor kidney function, is now really, the lines between 1, 2, 3, 4, 5 are disappearing, because the management, both vis-a-vis the symptomatic management and so-called disease modifying agents, are now acting on both systems. And therefore, this classification may be of value in interactions like this, where you want to, make uh, clear-cut definitions that this is heart first, then kidney, or kidney first, then heart. Actually, in clinical practice, this disappears. So for academics, for teaching, for maybe research, you can use this classification, but essentially I would say it's no more for clinicians real classification. And as Dr. Chopra suggested, that it's now intermingling of the two specialities, and which is very great that both specialities realize the value of the other specialities. And the type of workup we do for patients on dialysis, the cardiovascular workup or for transplant, is much, much now better than what we used to do a decade back, because we've realized how intertwined the two systems are. That's what I would say.
Yeah, thank you, Dr. Sanjeev. And I think spot on. And I think he's been absolutely right. And this is actually the viewpoint of some of those who actually coined this term. They said when we did that almost like 2.5 decades ago, there was a need of having sensitizing everyone to the fact that one organ is affecting the other, and people wanted a proof, and that is why we said, okay, look, this is the pathophysiology behind it. But yes, when it's a patient in front of you, obviously there's a merger of the symptomatology, and you may not actually be able to pinpoint as to what started. So my next question is to Dr. Kamal, and I think taking it further from where Dr. Sanjeev left. Do you really agree with this statement, Dr. Kamal, that it becomes extremely difficult for us to know as to the chicken and egg thing, which came in first, whether it was the heart first or the kidney first? And even though Dr. Sanjeev may have said that it is not of relevance, but so many times you may believe that, okay, if I have some better information, maybe my management may change a bit. So would you agree to that? And do you think in your clinical practice you can say with conviction, with surety, that look, it was heart first to begin with? Right.
Dr. Kula, thank you so much. It's very difficult and can never be said definitively that which one drew first blood, whether it was the heart or was it the kidney first. And the classification, as Dr. Saxena just succinctly put it, it's nice to have a classification probably for publishing your studies or looking at the data. But at the bedside, it's extremely difficult to know which organ was the first culprit and which drew first blood. We very often see patient directly on the bedside who's breathless and has a low urine output, creatinine is higher side, and the echocardiogram is showing. So which was first? It's very difficult to say so. There are few pointers that may help us say which was first. Like, for example, ultrasound abdomen of the kidneys may show some echogenicity or some particular differentiation loss of it. Maybe proteinuria, or the patient says I had proteinuria for particular some time. When the creatinine is disproportionately higher than to the degree of cardiac failure, or vice versa. But all these are probably on day one, and as the days go on, they become more and more blurred. Some biochemical markers like Dr. Simran just put up, like BNPs, ANPs, CNPs, or troponin I's may point to an initial cardiac insult and then a renal insult later on. Because we all know that creatinine takes a long time in increasing, hours to days sometimes in increasing. For the creatinine tend to stay at the baseline until 50% of the kidney function is lost. We all know that. And that's because the remaining nephrons start hyperfiltrating. So creatinine is a very poor marker to show how much of kidney function has fallen, say from 120 up to 60 or 50, and later it starts rising very rapidly. So other markers probably like cystatin C or NGAL or NAG, these have helped to say, okay, there's a tubular injury going on, it's probably the kidney. But as Dr. Saxena said, and as Dr. Vijay Chopra also said, the classifications, the 5 classifications probably need a 6th classification, an undetermined or unknown classification where we can put 80% of patients into it, because we simply don't know which started first.
So you're quite right when you give that statement, Dr. Kamal. And if I were to make a statement that, well, this kind of demarcation is probably more apparent in the acute settings, will that be a correct statement to make when I say that it is acute heart failure which leads on to a person who had absolutely normal renal functions till about a week ago? He may have actually got them done for some reason or the other, or just a health checkup, and now you find that person landing up in the hospital with acute decompensated heart failure right in front of your eyes. You have a worsening renal functions, then probably. So here we know that our judgment should target the heart issues first, because that is certainly going to indirectly help the kidneys as well. While I totally agree with everyone here that there is the distinction becomes indistinct when it comes to more chronic conditions, especially both the heart failure and the kidney failure. So, but taking it forward, Dr. Kamal, do you believe the what could be the pathological the pathophysiological reasons behind it? Do you believe there are some common inflammatory things responsible for it, or the hemodynamic changes will suffice to account for what we are seeing in front of us in that patient?
It's $1 million question, isn't it? It's if it was as simple as a hemodynamic process, it would have been very easy, and diuretics would have won the battle long ago. We all know that it's a combination of hemodynamic, neurohumoral, as well as inflammatory markers, all of them put together causing the problem here. Which is the first is always hard to say, as we already just spoke about the clinical conditions. But we now know, have a lot of data that it's actually not lessened renal perfusion per se because of a low cardiac output, but more of an increased CVP or a renal congestion, which is actually the bigger culprit in causing a kidney dysfunction, which in turn gives rise to more renin-angiotensin system and systemic neurohumoral responses, which cause more and more water retention. And also, they also trigger off, the RAS system also triggers off other things. Like IL-6 and TNF alphas and all kinds of cytokines, which cause inflammatory damage as well. So it's just not one single basket that we can put into, but a very complex, very complicated interplay of several systems which are all working at the same time. They may start off, one may start off earlier than the, but at a given point of time, we see all of them acting in tandem and causing a severe injury both to the heart as well as the kidney.
So quite appropriate, and I would believe that we need to take into account all those possible incriminating events, which can certainly give rise to a vicious cycle, and then finally it is where the patient lands up with. So Dr. Rishi, this is where we would want to hear from you. With your vast experience managing the condition in the Indian context, we all as nephrologists believe that we South Asians are different when it comes to diabetes, when it comes to diabetes affecting the patient's kidneys as well as the heart. Do you believe that in the Indian context, the kind of variation in the diabetes onset as well as progression, as well as the same holds true for hypertension. Do you believe we see a different kind of cardiorenal syndrome patients in our patient population, or do you believe they fit in whatever has been described in the literature for the in the Western literature?
So thanks, Dr. Kulla, for the invite. Very happy to be a part of this program. So coming to the question directly, you see, we know that Asians are different, and we know that we have diabetes much earlier in our population than in the West. And whether it's just the diabetes of the young or diabetes of the non-obese, those are classical like an Asian thing. Plus, you have something like uh, accelerated atherosclerosis in our population. So all of these together, we see a different kind of presentation to the cardiorenal syndrome than in the West. That being said, if I just look at the proportions, then yes, type 1 CRS is still the maximum in our population, followed by type 2, as it would be in the West. However, I do believe that the median age at presentation is much earlier in our country as compared to the West.
So quite true, and I think we certainly are the worst affected in our geographical area. I mean, we as South Asians and certainly Indians in particular are worst hit by just not the increasing incidence of diabetes and hypertension, but also the kind of effects they can bring into our patients. So we certainly need to be more energetic and proactive in our management of our patients. So certainly point well taken. So with this brass tack knowledge, let's move on and try to see how can we best manage these patients. So may I begin with you, Dr. Rushi? How would you typically manage your patients? We know on one hand, it was always described that, well, diuretics are great drugs to have in your armamentarium, but they may not necessarily be offering any mortality benefits. That's one. But we know we cannot do without diuretics. And certainly, so many times, as and when the renal failure becomes more and more advanced, we will find that diuretics fail. So what are your strategies? Do you, starting from the day you see your patient, and then typically you find this patient land up in the ICU, how does your strategy change? When do you bring in other weapons in your armamentarium when it comes to managing cardiorenal syndrome? The absolute basics to begin with, as we move on to the newer molecules we have up our sleeve. Yeah.
So I think I should thank Simran for the presentation, because that has kind of explained most of this question quite in detail, what we are discussing right now. So obviously, the mainstay of therapy remains use of diuretics. And here, we start with loop diuretic, and then we attempt sequential blockade when we have diuretic resistance. And I believe all of these terms are well known to our audience, so we'll not get into those. But basically, it starts with using a diuretic, increasing the dose, and adding a sequential blockade like a thiazide to a loop diuretic, and so on. And basically, we try to maximize the effect of the diuresis, because that is what we need from the clinical standpoint in these patients who have excess of salt and water retention. Now, if you look at data, till 2015, most of the data argued only in favor of using diuretics. And however, just last year, I believe there was a review in a ESC journal, the European Society, which looked and said that, in patients who are requiring very high doses of diuretics, usage of therapies, what you are trying to allude to, like slow continuous ultrafiltrations by any technology, that has actually shown to reduce the length of ICU stay, as well as reduce the risk of readmissions in this population. So that was actually a meta-analysis of around 13 odd trials looking at use of ultrafiltration in refractory heart failure or refractory CRS. So, I mean, it's a very difficult question to answer, because I believe every patient is going to make you titrate your management to his particular condition. You have obviously tried all the drugs that we spoke about uh, in the management of CRS, right from the SGLT to the ARNI to the AR to the aldosterone antagonist, everything to the patient. And then you are maxed out on the diuretics is when, from a clinical standpoint, that is when you start discussing, should I try ultrafiltration? And we all are aware of the Starling's law. We know that, if you are able to reduce the preload, you will, at a certain point, you will get a benefit in improving the function of the myocyte. That being said, it is easier in theory than in practice, because trying to ultrafilter a patient with a blood pressure of 90 systolic in the patients with heart failure is not exactly a cup of cake. It is not something that you are going to be recommending to patients easily. Also, trying to put an invasive treatment in some patient, I mean, it's not like a bridge. If it's like a bridge to a something like a refractory heart failure going for either a destination therapy or a transplant, then it's another story. There you would definitely intervene with more procedural therapies. Otherwise, in most of our patients, 99% of our patients, you are just going to basically, keep diuretics as the main pillar of therapy in managing these patients while they are in the ICU also.
Very appropriate. And I think, as you very rightly summed it up, saying that it's very difficult. I mean, it's very easy to say that, okay, we have plenty of weapons in our available to us. But then when it comes to actually using them, I think you struggle at times, because it's very easy to say, okay, use diuretics. But then, as you rightly said, the patient's blood pressure is just about 80 systolic. Then what do you do? And you know that your patient is struggling to breathe, and you know the ultrafiltration is probably the right answer. But it is, the patient may actually collapse the moment you put him or her on any kind of extracorporeal therapy. So I think, but what is important is to remember that it is basically the judicious use of your weapons. And I think, and with that, we need to master the art of using the diuretics as best as we can. I mean, so many times we may be escalating the dose of diuretics, not realizing that the patient is having a liberal dose of salt, and he's not restricting with the fluid intake. So there is no point moving on or adding one to the other unless you have taken care of the absolute basics. And small tips like you give, if you have to give thiazides or metolazone, maybe about half an hour or 1 hour before you give a loop diuretic. So drugs like and when do you add on to give mineralocorticoid receptor antagonists, because you know that so many times you are encountering resistance to the diuretics. You have, as was pointed out, the breaking phenomena. So this is what you need to know and discuss in forums like this, that we are able to take care of the patients as best as we can, as it said. And ultrafiltration or overzealous use of diuretics can actually perpetuate the cycle. You may actually render the patient volume depleted. So it's an art to know the volume status. And this is what our department keeps on discussing with stalwarts like Dr. Chopra, and take their help and keep on redefining the patient's volume status, because ultimately, at the end of the day, it is the correct assessment of the volume status which will tell you. And we have ways to do that now. It is not just the clinical examination. We rely very heavily on POCUS. We rely on the cardiac echo findings. We rely on bioimpedance. So there are objective tools to help us do that. So that's extremely important. But now, Dr. Chopra wanted to make a point. Dr. Chopra, I see your.
Dr. Khullar, 2 points. I think one, of course, is that despite the dose trial and everything, all of us use infusion of diuretics, loop diuretics, when you are really stuck. The other point that I think the physicians would really like to know is, after you have diuresed the person, now if the creatinine clearance is say 30, or say it is 45, or it is 50, when do you introduce aldosterone antagonists, ARNI, and SGLT2 inhibitors? I think that is the question I think specifically should be answered. That is what the physicians would like to know.
Yes, so I'm coming to that, sir, and I think this was just the beginning because I couldn't have expected anyone to answer this better than Rishi as far as the absolute basics of management of heart failure is concerned, and this is so very close to every nephrologist's heart. We're talking about cardiorenal today. The pertinent use of diuretics, and taking a cue from what you have really mentioned, we will move on and ask Dr. Saxena. Dr. Saxena, what is your take on the usage of SGLT2 inhibitors? We have learned a lot, as Dr. Chopra said. I mean, we woke up to the reality that SGLT2 inhibitors are great drugs, not just for the heart, but then what Amparec showed as the post-hoc analysis that it's good for the kidneys. That's when we had the dedicated trial like Credence, DAPA, C-Kidney, and EMPA Kidney. So what is your take? We have realized that they work beautifully even when the GFR is quite low. We believed that they will work only if the kidneys are all right. They will work via the kidneys. And then we have realized even in patients who have very, very advanced stages of chronic kidney disease or renal failure, they still work very effectively. Is it some direct effect on the heart or some other? Please throw some light and your take home message to everyone who has joined us today. What kind of confidence can they repose in SGLT2 inhibitors vis-a-vis the GFR of a given patient?
First, I think about the diuretics, it it may sound a little tough, but it's not that tough if you can classify your patient into two types. One is he volume overloaded or is he only congested? If you have acute heart failure, then he's congested. And if he has chronic heart failure and chronic kidney disease, then he's probably both. And therefore, the diuretic use would be best if he is volume overloaded with congestion. In the only congested patients, it's a little, it will bring down your GFR. And the point that Dr. Chopra mentioned, our cardiologists have some resistance. Because of that trial, they feel that, 40 milligram 8 hourly is as good as giving an infusion. Whereas our experience over the years has been the infusions somehow seem to give much better outcomes. I don't know what Dr. Chopra would like to say on that.
So I think it's not
Agree with
just
you.
about it's not just about the intravenous route of administration. Now it's debatable whether you give infusion. Even if you have to use infusion, I think it's very prudent to first give upfront a loading dose.
Loading dose.
Unless you
That's
have,
right. That's right.
yeah, so you
Yes.
give a loading dose, then infusion,
Then
or you
infusion.
give IV boluses, they may work. But what is important is so many times they have to reach the loop of Henle, and it's the albumin which actually is going to do the trick. So many times we find ourselves giving them along with albumin, especially in people who have dearth of albumin in their body. So it's as I said, so reinventing what we have learned over the years about the pertinent use of diuretics. This is the kind of message which only the stalwarts like you all, the elite panelists today, can throw light to those who have joined us today. But then, Dr. Saxena, your points well
Yeah.
taken. About
The
SGLT2 inhibitors.
SGLT2, I would say that as soon as the patient can, you should start SGLT2 inhibitors. And there is enough evidence now that even at low GFRs, as low as 20, you can start. And if you have started earlier, well, you need to continue them. And the reason behind that is not far to seek because they don't only work through the tubule and the glucose loss and the sodium loss in the kidney, but they have many pleiotropic actions, and many of the actions work on the inflammatory markers in the cytokines, and these are beneficial both in the kidney and in the heart. And therefore, you don't need to have a well-preserved tubular glomerular feedback alone, which means that you don't need a very good kidney for their action. And therefore, it's now among the first line, top line drug for CRS. And of course, for nephrologists, it is a top line drug for non-CRS patients also.
So,
And
so
Of
also
course,
it
you
doesn't
must
cause
know,
much of
as I shouldn't
doesn't
say
cause
that
much.
alone. I must qualify that, of course, you must look at contraindications, and that I think is another
so
topic.
very clear and loud message, and I think our stands, a few of us who believed very firmly in SGLT2 inhibitors way back, almost like a decade ago, the stands vindicated, because there was a lot of skepticism, even amongst many of the nephrologists' mind to begin with, when we were criticized that you can't have too much of faith in these, because the drug which is going to work via the kidneys, how will it work if the GFR is low? And that is what the trials showed, that it works at 45, it works at 30 with credence, it works at 25 with APA CKD, and it works equally well with AMPA kidney at GFR as low as 20. And then the interesting thing is what we realized, and we have discussed it in this forum as well in the past, that even those patients enrolled in DAPA CKD trial who landed up in the stage of dialysis, they did better than those who did not receive SGLT2 inhibitors. Even though the numbers were very small, it was not by design that they were allowed to continue SGLT2 inhibitors even when they had reached the stage of dialysis. But the fact is, they did at least numerically better than those who did not receive SGLT2 inhibitors. And then, of course, whole lot of heart failure trials, we know that they also had patients with significant compromised kidney conditions, and yet they could demonstrate that they work wonders. So certainly, SGLT2 inhibitors are here to stay. We have learned a lot via these impressive molecules, and it is about taking them to the next level, which means the way we talk about the RAS blockers as the absolute, the baseline necessity. And then we talked about drugs like SGLT2 inhibitors and Finrenon in the same breath. Now we are saying that, okay, the standard of care indeed is SGLT2 inhibitors. Now let us try and see what the newer drugs, as Dr. Chopra was alluding to, be it baxdrostat or vicadrostat, or even the soluble GMPs, the vericiguat, and now we also have nurandiciguat. So whole lot of new molecules which are being bombarded, but SGLT2 inhibitors have created a niche segment for them, and I think we can't thank these molecules enough, the kind of care they are taking of our patients. But I did mention about RAS blockers, and then Rishi, it's over to you now to tell us how do you judiciously in your clinical practice use RAS blockers? Because ever since we became nephrologists, the first question which was being always asked to us was, when do you stop RAS blockers? When during the course of CKD would you want to stop? So I want you to, if you are as excited about the usage or what they do to our patients as far as RAS blockers is concerned, give that confidence to those who have joined us today, that we should not move away from the great role which they play, and at what stage, till what stage, and how best should we use it.
So, to answer it succinctly, I would say that, they are the mainstay of our treatment. And when we say RAS blockade, we include the ARNI as part of it. And that we all know has become the cornerstone of treatment for CRS. Now, the question comes in real life. At what point are you comfortable continuing the RAS blockade? Till what levels of creatinine or EGFRs? So the answer to that is that as long as the patient is passing a decent amount of urine, we should not get too perturbed by the rise in creatinine or the drop in EGFRs. The only time in clinical practice that you actually have to stop an ARNI or an ARB is when you have refractory hyperkalemia not responding to standard line of treatment, including the best that you could have done with your dietary adjustments and your potassium binders. One trick which I believe a lot of us do practice, which we should pass on to everyone, is the way we would add the sequential drugs in management of CRS. So an ARNI, if you're going to follow it with, say, Finrenon, your risk of hyperkalemia is little higher as compared to, say, an ARNI followed by an SGLT followed by Finrenon. Now, why would that happen is very obvious, because SGLT includes natriuresis, aquauresis as part of the osmotic diuresis generated by the glucose. However, if you were, so the sequence at which by which these drugs are added can play a role in preventing hyperkalemia, which in my opinion is one of the only few reasons where you really need to take RAS inhibition off the table. Because, and whenever, even if it is off the table, the next thing that comes to my mind is how soon can I reintroduce a ARB? And the smallest dose of ARB that the patient can tolerate, I would like to restart as soon as I get an opportunity and the hyperkalemia is under decent medical control.
So I think the one message is very, very clear that RAS blockers are great molecules, but then he's at the same time given us the caution that hyperkalemia could be the stumbling block. Dr. Saxena, this one is for you. How would you in 2025 manage, overcome this fear of hyperkalemia? All right, and what is the best strategy? Like, you see, you definitely want to give the benefit of RAS blockers and of maybe finerenone as well, or maybe if GFR permits, potassium permits initially, the conventional mineralocorticoid receptor antagonist, right? So how would you mitigate the occurrence of hyperkalemia and manage it if it happens?
I think it's a tough task in several of the patients because they have underlying diabetes. And the diabetics are, prone to type 4 acidosis and potassium. So I think the first thing is you must look at their baseline potassium. If their baseline potassiums are very high, then you need to be very cautious. Second thing that you must look at is how compliant will this patient be. If you give him Arni, if you give him Phenerenone, and you send him home, if you are calling him in 2 weeks, will he come in 2 months or 2 years? So you got to ensure that you have educated him well and have put the fear of hyperkalemia in his mind. Apart from that, the usual measures, first is the diet. And it's a good practice to teach all of them, even if they don't have hyperkalemia, to leach their vegetables and dals and teach them about the intake of fruits and which fruits contain what potassium, how much potassium, all that. So diet is
If I may
important.
interrupt you at this stage, Dr. Saxena, there's a very interesting comment by one of those who have joined us today, Dr. Surinder Gupta. He says that, yes, we also need to be mindful of the fact many of our patients could be taking diet rich in potassium like makhanas and chukandar and coconut
Correct.
water. And you're absolutely right. And I think this is what
Yeah,
the
this is,
point Dr.
we don't spend time on diet and must emphasize because, and of course, the biggest culprit that a nephrologist sees are the rock salt and Lona salt, both of which contain high potassium. So these have to be told and emphasized. Besides that, I think if the hyperkalemia is not tremendous, so if it's say between 5 and 5.5, you can keep giving with a closer watch. If it is beyond 5.5, 5.5 to 6, then I think it may not be a bad idea to combine them with a potassium binding resin. And if that works, and addition of a diuretic and a little bit of soda bicarb, these three things do help them in their management of potassium. If it is 6 and above, well, I think it is time to relook. These drugs may be great, but the hyperkalemia, it can be a killer. And in a year, because of these drugs, several times we have paced these patients in an emergency because the bradycardia is so severe that we know by the time we are able to extract the potassium out, they may not survive. So quick temporary pacing, and then you remove their potassium by dialysis or whatever means.
So, and I think I'm sure you'll agree that our practice pattern may change with the availability of the novel anti-hyperkalemic drugs
Correct.
once
Which is about to be
they're
launched.
about. So once we
Yes.
have drugs like Localma, which is zirconium cyclosilicate, I mean, of course, cost is one big issue with them, but then maybe you will be able to chronically use these drugs like ACE inhibitors, ARNI, Finrenone,
Yes.
etc. so that we give maximum benefit to our patients, yet not fall in the trap of hyperkalemia. Because for those of us who routinely come across the wrath of hyperkalemia, I think you will dread using
Yes,
them in patients who are
correct.
predisposed to. And I think let's take this discussion. I'm thoroughly enjoying, as you can see. I don't want to let go of this opportunity of learning from my elite panelists, but then I think ultimately time will come where I'm going to get a signal from Intas people. But then I think, to full credit of Intas, as I've always been saying, they have been doing it absolutely selflessly, and the tremendous work, like people at the helm of affairs, Mr. Amit Arora, with his very able team, Dr. Mithlesh and Mr. Gaurav Khanna, who are doing wonders. And absolutely, as was agreed upon, no branding, as you can see, absolutely top class academic activity without any of their personal interest. And I salute them for the kind of initiative they have taken. But just to wrap up, few questions. Dr. Chopra, this one is for you. Dr. Viren wants to know the kind of clear class benefits which all these drugs have shown. Which one would you begin with first? RAS inhibitors, MRAs, SGLT2 inhibitors, sequentially, all in one go? What is your strategy as of today? Dr. Chopra, you're unmuted. Yeah.
Now, as far as heart failure is concerned, now there was a strong HF trial which was recently published. What that has shown is that it is better to start all the 4 drugs as far as possible before the patient is discharged after acute decompensated heart failure. Call them after a week, try to up-titrate them, and have all the 4 drugs on board within first 6 weeks to the maximally tolerated dose, because that shows reduction in mortality, reduction in rehospitalization. Which order you start with, it all depends upon the hemodynamic and renal profile of the patient, various things. For example, if somebody has tachycardia and they are euvolemic, you'll probably start with beta blockers and then add on things like SGLT2 inhibitors. See, the advantage of SGLT2 inhibitors is that they do not cause any hemodynamic or electrolyte disturbances of any significance. So they are, easy fruit to pick. On the other hand, if a person is still congested, they are still dyspneic by the time they are discharged, then probably you'll go with SGLT2 inhibitors. And if the blood pressure allows, add on ARNI and aldosterone antagonists. Maybe to control the heart rate, I would use ivabradine. And once their congestion is under control, then add on beta blockers. So similarly, you have to play around with these drugs. This question about which sequence to use, that is, there's no hard and fast rule. You have to see the clinical profile of each patient. But then all 4 drugs should be on board as far as possible, as quickly as possible.
So, thank you very much, Dr. Chopra. A quick one. Now we are running out of time. What is your approach for HFpEF? We know ARNI, etc. They are proven for
Okay, so
HFrEF, but
yeah,
how do you manage HFpEF?
So HFpEF, till recently was an entity in search of treatment. All that we had was diuretics and then management of comorbidities. Thanks to the recent trial, okay, let's start with the oldest one. ARNI has shown benefit in ejection fraction below 57%, and in women more, and in those who are recently discharged from acute heart failure hospitalization. As the EF keeps dropping below 57, there's an incremental benefit. SGLT2 inhibitors, we know that they are beneficial across the spectrum of heart failure, which has been shown in several clinical trials. Aldosterone antagonists, the conventional ones, the spironolactone and eplerenone, they're established as far as reduced ejection fraction is concerned, but finerenone has been shown to be beneficial in heart failure with preserved ejection fraction. STEP-HF showed us that in people who are obese, who have heart failure with preserved ejection fraction, there is a benefit of starting GLP-1 receptor agonists. So these are the 4 drugs. Now these have become probably the 4 pillars of heart failure with preserved ejection fraction also.
So thank you very much, Dr. Chopra. And I think at least there's hope now, even for people with HFpEF. We were struggling to first diagnose and then to effectively manage these patients. But again, there is a lot of hope for these patients. Dr. Kamal, this one is for you. Dr. Patil wants to know, which is your favorite, chlorthalidone or hydrochlorothiazide in the context of CKD? We heard Rajiv Agarwal talk a lot about this chlorthalidone, and he had posed his confidence in that. Would you want to advocate that it has a clear-cut advantage over the traditional thiazides, which means thiazide-like and thiazides? Is there a relevance to have this kind of demarcation? And is chlorthalidone your favorite as well?
Thank you for that. Um, as nephrologists, we always have combinations of these drugs in ARB with hydrochlorothiazide or chlorothalidone added on to it. They are pretty good as diuretics, but they're not very, very powerful diuretics. Not as powerful as, say, for example, a metronidazole is, for example. And in people with cardiac failure, when we have reached the maximum doses of loop diuretics, the next thing that we would like to add on is a metronidazole and not actually a chlorothalidone or a hydrochlorothiazide, because our experience, what of the studies, our experience shows that metronidazole is far more powerful in doing. Of course, we also see a lot of sodium losses with it, and also we actually see clinical hyponatremia in these patients, which then actually helps us, and hypokalemia as well, which actually helps us to put on the ARBs or AC inhibitors with a far more confidence, because we're not worried about hyperkalemia much as we would have been earlier. Between just both of them, chlorothalidone and hydrochlorothiazide, I really don't have much of a big preference. I really don't think there's too much of a difference between both of them.
Rishi, this last one is for you. Dr. Taranath says that we can try and use dopamine infusion in our patients during dialysis, give them the benefit of dopamine to sustain blood pressure and then achieve the ultrafiltration. So this is one way of enhancing the fluid removal during ultrafiltration drive. Do you agree with that? Do you use it in your clinical practice? Dopamine infusion, for that matter, any other inotropic agent?
Short answer is no. Uh, the the reason is that using a vasopressor to improve ultrafiltration works in a very transient form, and there is no sustained or long-term benefit of doing this kind of volume removal in most of our patients. That being said, in refractory cases where you are just unable to achieve any ultrafiltrations, and some of them require to be on inotropes, not so much for the ultrafiltration alone, but from the fact that they are hypotensive in their presentation in the ICU. So there are these patients where we have attempted, but I can tell you that 9 out of 10 times we don't make it. These
Well,
patients
thank you
won't
very
make
much.
it.
Thank you.
Or
Thank you very much.
adrenaline may be a good thing to use. And
in case you are
wherever there is,
struggling.
yeah.
Yeah.
You have
So,
been through
Dr.
that, right?
Saxena,
Drupa,
last one.
NORAD,
I'm sorry, the
yeah.
time is really running short. The last one, Dr. Saxena, any message for the management of cardiorenal syndrome in the elderly subpopulation, or would you not be scared of the use of these pillars of therapy which we have? Do you believe the elderly are different, whereby you are not looking at the progression, you are looking more at alleviating their symptoms? Yeah.
I think bulk of the most of the drugs we have discussed have been proven to be fairly safe in the elderly. And therefore, just because somebody is 70, 75, we are not looking at managing him symptomatically. We got to manage him also for preservation of his renal and cardiac function. And therefore, SGLT2 inhibitors, ARNI, both have been shown to be clearly safe in the elderly, and therefore they can be used. Phenylenone, I think there is not enough evidence to say that it is can be used in the elderly, but I may be wrong in that. I'm not sure.
So, I mean, there is accumulating data which says that yes, the safety concerns are not there initially, what we had initially thought. So, but we have learned a lot via the fine hearts. Fine hearts probably said that yes, it indeed is very good for the heart, but then it didn't prove a point that it is equally good for the kidney, at least in that trial. But we have a lot of things to learn, and by the time we get familiarized with drugs like mineralocorticoid receptor antagonists, we also know that why not target aldosterone itself rather than looking at the receptors. And that's why we have aldosterone synthase inhibitors, a whole lot of. So I think I'm quite excited as to what the future has in store for us. So I think we end here. And I'm sure everyone who have joined us today will agree to one point, that I have done my duty quite well. I've been able to bring to you the best of the people in cardiology and nephrology today to do justice. Simran was terrific as far as her presentation was concerned. Thank you very much, Simran. If I had more time, I certainly would have loved to listen to you answering those questions as well. But then I probably got so much engrossed in what I was learning from my other friends that this got omitted as far as asking you some direct questions toward after your presentation is concerned. Over to you, Dr. Mithilesh. And once again, thank you, Intaj, for this great work which you've been doing. Every time we know that the NephroLive is gaining in popularity, every time we get to know that the number of joinees has exceeded the previous editions. Last time it had already exceeded 2,000. This time I was told midway by Gaurav that we have already exceeded 1,1700. What is the final figure? Over to you, Gaurav, and then vote of thanks by Mithilesh. Thank you very much for overshooting
One
the
one
time. My
very quick,
apologies as far as that is concerned.
Dinesh, on a very lighter note, a very quick note. Those two big studies about Finerenone, Moonraker and Thunderball are two very famous James Bond movies.
Yes, absolutely right. Yeah.
Correct.
So as I was alluding to, nephrologists didn't want to be left behind. We are in majority today, and Dr. Chopra, you can't talk about Moonraker and not allow the nephrologists to talk about Thunderball. It's all about James Bond. Over to you, Ditlesh.
Yeah.
Dinesh, don't forget all the evidence came from cardiology trials.
I think I must admit the fact that we owe you a lot, sir. I have to enter my hospital tomorrow, so I can't afford to annoy you.
Yeah. Thank you very much, sir.
Yeah, please go ahead.
Yeah. So on behalf of Intas Pharmaceutical Limited, it's my privilege to offer a vote of thanks. So first, special vote of thanks to our speaker, Dr. Simran, for delivering insightful talk, the clarity with which the complexity of this critical topic were discussed, the cardiac and renal care were explained, and definitely enrich our understanding. I would also like to sincerely thank our esteemed panel member, Dr. Chopra, Dr. Kamal Kiran, Dr. Rusi Deshpande, for their thoughtful contribution and real-world clinical perspective during the engaging panel discussion. And as always, our deepest appreciation goes to our co-director, Dr. Dinesh Kullar, sir, for his continued leadership and for shaping NephroLive into an academic platform for immense value. And lastly, a special thanks to our audience for your active participation and enthusiasm. We look forward to welcoming you to our next episode with another important topic. Till then, stay safe, stay updated, and good night to everyone.
Gaurav, how many did finally join today?
Sir, final number which I am having is a 2052, which I can count at 9. So final number will
Yes.
come. I will post in the group, sir.
I hope you have counted 6 of us also.
So it's gaining in popularity. So it's as I can say, it's all-time high today. Thank you very much.
Yeah.
Thank you,
Yeah.
wonderful audience, for making us feel wanted, and thank you. We will try to make sure that we live up to your expectations in our future editions as well. Thank you very much. Have
Thank
a
you,
great
sir.
Bye. Good night.
Thank you very much.
sir.
Good night, sir. Good night.
Bye.
Good night, sir. Good night.
Good night, sir. Good night. Good night. Sir.
Thank you, sir. We are offline now.